Welcome to The Explainer. Today, we're taking all that dense pharmacological data on epoetin alpha and darbepoetin alpha and turning it into something you can actually use on the floor. If you manage patients with severe anemia, well, you simply can't ignore this foundational knowledge.
Here's our roadmap for today's explainer. 1. Action and common medications. 2. Administration and target levels. 3. Contraindications and interactions. 4. Side and adverse effects. 5. Essential nursing considerations. And finally, 6. Client education and self-care. Let's get right into it.
So, picture this. You've got a patient presenting with severe anemia, but a blood transfusion is completely off the table. Maybe it's a specific medical condition, antibody issues, or, a supply shortage. What's our most effective clinical solution to get their body functioning properly again?
Section 1, Action and Common Medications. The answer? Erythropoiesis-stimulating agents, or ESAs. You probably know them by their brand names like Epigen or Procrit. Basically, these drugs act as a synthetic version of the hormone erythropoietin. They jumpstart the body's bone marrow, turning it into a rapid-fire red blood cell production factory.
Now, looking at these medications side by side, check out this critical difference. They both do the exact same job, right? But darbepoetin alpha, Aranesp, has a much longer half-life. Because it hangs around in the body longer, the patient gets a much easier, less frequent dosing schedule. And honestly, that is a huge win for patient compliance. Moving on to Section 2, Administration and Target Levels. Okay, 11 grams per deciliter. I really need you to burn this number into your memory. This is an absolute hard clinical boundary. If a patient's hemoglobin levels creep over 11, you stop administration immediately. Remember, we are absolutely not aiming for a high or even normal hemoglobin level here. To safely manage that tight target, we rely on a really strict titration protocol, all based on continuous lab monitoring. First, you always get a baseline. Then you administer the absolute lowest effective dose. You titrate it super carefully based on how their labs respond. And lastly, you enforce a hard stop the exact second that lab result hits over 11.
All right, Section 3, Contraindications and Interactions.
Listen, you must never administer these agents if your patient has uncontrolled high blood pressure or specific hypersensitivities, like an allergy to albumin or pure red cell aplasia. It can literally be fatal. The body just can't handle that kind of compounding strain.
While you always need to monitor for drug interactions, there's actually a super unique nutritional quirk with ESAs. Without adequate iron supplementation, the bone marrow just doesn't have the building blocks it needs to make those red blood cells. Think of the ESA as the construction worker, but iron is the bricks. Without the bricks, the drug is basically useless.
Let's look at Section 4, Side and Adverse Effects. We can easily group the most common side effects into 3 buckets to help you remember them. First, cardiovascular spikes, especially hypertension, since we're increasing blood volume. Second, you've got general body aches and headaches. And third, localized injection site issues, since, we're giving this subcutaneously. But here is the most crucial point, the toxicity warning. This circles right back to that strict 11 grams per deciliter limit we talked about. If hemoglobin rises too fast, the blood essentially gets too thick. This severely overloads the cardiovascular system and wildly increases the risk of strokes or heart attacks. Bringing it into practice with Section 5, Essential Nursing Considerations. As our source material clearly highlights, continuous blood pressure monitoring before and during therapy is primarily on the nursing staff. Knowing what we just went over about hypertension being a huge contraindication and a major side effect, checking that blood pressure is completely non-negotiable. On top of that, you have to be super vigilant about assessing the patient for any signs of deep vein thrombosis or unexpected seizure activity throughout the whole treatment cycle. You are literally the first line of defense in catching these adverse toxicity warnings before they turn into a full-blown crisis. Finally, Section 6, Client Education and Self-Care. This brings up a really vital question from our source material. What exactly does a patient need to master to safely take these injections at home away from our constant medical supervision? Well, for starters, they have to nail their subcutaneous injection technique to avoid tissue damage. They also need to recognize the physical signs of soaring blood pressure so they know exactly when to call a doctor. Plus, they have to treat their iron supplements and their frequent lab appointments as absolute necessities. Skipping labs means flying blind, and with ESAs, there's just no way around it. That is incredibly dangerous. Ultimately, the whole success of Epergen or Aranesp comes down to a really delicate balancing act. You're weighing the cure for anemia against a severe risk of cardiovascular overload. It's basically a tightrope walk, completely guided by strict protocols and non-stop monitoring. I'll leave you with this final thought to guide your clinical practice after watching today's explainer. Are your patients' hemoglobin levels effectively treating their anemia, or are they quietly putting their heart at risk by pushing past that critical 11-gram threshold? Definitely keep that in mind next time you review a patient's chart.